I'm going to talk about the use of OCT in diabetic retinopathy and retinal vein occlusions. Why OCT in these situations? Because as we all know, OCT is more sensitive than clinical exam in picking up subtle edema. It is non-invasive, objective, repeatable, and structural changes are seen so vividly, and we can pick up the vitreoretinal interface problems and traction much more easily on OCT than clinically. So all this has bearing on the treatment of the condition. We need to assess the response to therapy and plan retreatment. All this is possible only with the help of OCT. So here is a patient who has 6/24 vision. He's a diabetic, came with decreased vision both eyes of few months duration. You can see clinically there are moderate NPDR changes in both the eyes with hard exudates. But look at the OCT, how vividly it shows the structural changes in the form of loss of contour, cystoid changes, spongy edema, and subfoveal serous detachment. This is the reason why we love OCT, in our day-to-day practice, why we use it so extensively, because it shows the details so well. The changes that we see on OCT can be classified broadly into 5 types of thickening. That is, one is a spongy thickening that you see predominantly spongy edema. Second is a predominantly cystoid macular edema, or a subfoveal serous detachment, or a vitreomacular traction or taut posterior hyaloid phase. Although we have categorized the changes into these subtypes, in clinical practice, as you can see here, is always a combination of these types of changes that we see. This patient has spongy edema. This patient also has subfoveal serous detachment. So it is quite usual to see a combination of these factors. And what you have to see is which is the predominant type of swelling that this patient has, and that may have a bearing on managing the patient in the best possible way. Fractional component in DME is something that we need to pick up because it needs surgical intervention, and injections may not help. And OCT is definitely invaluable in picking up this. This is a patient who came with blurring of vision. He had diffuse edema and he has NPDR changes. FFA was done and it shows diffuse leakage around the macula. Then you see, lo and behold, you see a vitreomacular traction causing the macular edema, and no amount of injections would have helped this patient. This patient underwent surgery, and you see subsequently restoration of the normal foveal architecture. Another patient who had PRP done, he had a thickened hyaloid face, his vision refused to improve beyond 636, and you can see that there is a spongy macular edema, cystoid change, there is an epiretinal membrane. We decided that this thickened hyaloid face is the cause for this macular edema and subjected the patient to surgery. Following surgery, you can see that the normalization of the foveal contour and vision improved to 6/18. And this is an example of OCT helping us to diagnose and decide regarding surgical intervention. Center versus non-center involvement has become an important point to distinguish now whether to treat or not to treat, because we do not need to treat every thickening that is seen on OCT. Like you see in this patient, this thickening that you see is away from the macula on OCT. Though clinically you see a hard exudate ring, patient's vision is 6/9, and this patient can be observed without offering any treatment in view of his good vision and non-center involving macular edema. On the other hand, this patient has decreased vision, and you see the extent of involvement on OCT, which involves the center of the macula with spongy edema and subfoveal serous detachment. This is a patient who needs treatment. So to decide whether to treat or not to treat, in addition to vision, the OCT is an invaluable tool. Another situation, asteroid bodies, very difficult to evaluate the macula, whether there is edema, no edema. OCT shows the presence of edema in this eye, and therefore even to monitor the treatment or plan the treatment here, OCT is an invaluable help. So once we start the treatment, without OCT, we cannot assess the response to therapy. Of course, patient's vision is a good way to evaluate. Of course, that's what we are all interested in. But it is much easier to evaluate on OCT the treatment effect. You see this patient pseudophakic eye with a diffuse macular edema with with a PDR post-laser status. This edema we actually watched for 1 or 2 months, and when it did not subside with topical drops and nepaphenic eye drops because patient was pseudophakic, we decided to treat with Ozurdex and look at the amount of resolution of edema. The other eye of the patient had asteroid bodies and a very similar picture, and also responded well to Ozurdex injection. with normalization. So you see the response to treatment can be assessed. And here I would like to tell you one thing, patient can appreciate the difference in the pre and post treatment OCT very well. And OCT is a very important tool in counseling the patient about the eye condition, why we are treating, how he is responding. Patients can understand OCT much better than a fluorescein angiogram or even a fundus photograph. So this is what I have seen. When you show them on OCT, the thickening and the resolution of the thickening, they are impressed. And definitely it's a very good counseling tool. Another example of an anti-VEGF agent being given here, there is a parafoveal spongy edema. Of course, there is a hard exudate plaque in this patient because of the chronic edema. But look at the response. The spongy edema has vanished after the anti-VEGF injection. But you all know that we need to continue the treatment. It is not the question of one injection. And again, another example of a good response following intravitreal injection. So to assess the response, we need to use the OCT. Here is a patient who received 3 injections. Vision did not change. Vision was maintained at 6/12. There was no change in the edema. And we decided to change the anti-VEGF from ranibizumab to aflibercept and look at the change that we could get, response we could get. So whenever you have a non-responder, we can only pick these up on OCT, and the response to the change in the treatment can be picked up on OCT. So all these decisions are possible only by serial OCTs. Can OCT predict the outcome? Because of the nature of this talk is only the basics. I am not going into the details of this biomarkers in these various diseases. I will just highlight 2 important biomarkers which are being talked about. One is the drill, which is disorganization of retinal inner layers. This is inability to distinguish between the ganglion cell layer, inner plexiform layer, and nuclear layer and the outer plexiform layer. Here you can see that these layers are seen well, but you can look at this side, all the layers have become indistinguishable. How do you see this? This is measured on OCT B scan by looking at the central 1 millimeter of the retinal zone around the fovea. And if there is this kind of a disorganization involving more than 50% of the area or more than 500 microns, this is considered a significant drill, and this has been shown to be associated with worse visual prognosis with edema or resolved edema. Mind you, in a patient who has cystoid macular edema and swelling, sometimes it is difficult to assess the drill. So when the patient responds and the edema resolves, then you can assess the drill better and see if this was the reason why this patient's vision did not improve. So drill is an important biomarker that is being studied not only in diabetic macular edema, but also in vein occlusions and in epiretinal membranes also. The other thing that hyperreflective foci or HRF or HRD, this has already been alluded to by Dr. Manjula in her talk. These are hyperreflective dots that are seen throughout the retina, even in the choroid. How do you distinguish from hard exudates? Hard exudates cause shadowing, and they are larger in size, whereas these are smaller in size and they have no back shadowing and reflectivity similar to that of the myofiber layer. So the size may vary depending on the treatment, and the presence of large number of hyperreflective foci is supposed to indicate an inflammatory pathology, and therefore these patients may respond better to a steroid injection. This is highlighting the hyperreflective foci that you see in this scan. So presence of HRF may tilt you towards giving steroid in that particular eye compared to anti-VEGF. So therefore, these biomarkers can also help us to decide regarding treatment. And just a brief word about vitreopapillary traction, which is picked up on OCT. This is a gliosis on the disc that is causing traction on the disc in this eye with PRP, post-PRP stable status, but he had drop in vision, gradual onset. There was a traction on the disc, and this was a vitreopapillary traction which is picked up on OCT. More examples of vitreopapillary traction that you see here. Following surgery, you can see that the traction is relieved, and we have recently, indicated this as an indication for surgical intervention in patients with PDR. And look at how OCT can vividly demonstrate the vitreopapillary traction, indicating the need for treatment. Vein occlusions, the use is very similar to what you use in DME. This is an example of a central retinal vein occlusion with diffuse macular edema. Branch retinal vein occlusion, here you can easily make out the difference between the normal uninvolved retina and the involved retina. Again, hemiretinal vein occlusion, hemi-CRVO, or a tributary vein occlusion. In all these situations, OCT invaluable in picking up the macular edema and guiding the treatment. You see the treatment response here to the anti-VEGF injection. In central retinal vein occlusion, this looks like a very florid CRVO, but look at the nice response that we have got following the injection. And again, non-responders here after 2 injections, there's hardly any response, and you see the response here that has the change. So in conclusion, OCT is an integral tool today to diagnose edema, diagnose needing treatment in both DME and retinal vein occlusion. It is invaluable in surgical decision making in order to pick up vitreopapillary traction, vitreomacular traction. Definitely needed to plan retreatment and change of treatment. It may be useful in predicting visual outcome, but it's not possible to. But today, let me assure you, it's not possible to manage diabetic macular edema and RVO without the aid of these OCT. Thank you. Thank you for